And what you're seeing is IPS kind of working as that kind of seamless package. There's no distinction necessarily between organisations and groups, but it's kind of recognising this is an integrated kind of package for somebody. They get their care coordinator support, they also get the employment specialist support. So it just happens as a kind of a seamless opportunity for people. The transition issue is really important. If we think about the previous graph I showed where the pink line was kind of fluctuating, it was fluctuating because people were moving in and out of education. And this is, we just took the folk at that start who were in education, so 100% of them were doing education. And then we kind of looked at kind of what's going on for them. And you can kind of see as the kind of the bluish graph drops, you see the kind of purple block starting to rise. And that's education, and that's employment. And as time goes on, you can kind of see that what's going on is as people are finishing their education, they're making that natural transition into the workplace. So in a sense, kind of dealing with that really important transitional kind of perspective. This is a study which we've finished quite recently. I kind of wanted to raise it with kind of two issues. One is the kind of the yes but issue, and the second part is the kind of issue about, well, there's a recession, it's very high youth unemployment, etc. When we were looking at our data and the kind of success that was going on, we sat down with the employment specialist, the team manager, and the psychiatrist and said, what's really going on? Yeah, people are moving into education and jobs. That's fantastic, but what's really going on here? And what came out was actually the team manager kind of said, well, think about it, probably about a third of people in the team come into our team and they want that help. Another third, when offered it at the initial assessment, say no. And then another third, they're not sure. And there was something about that kind of unsure bit and the no bit that we kind of thought about, well, how do we work with that? Because you don't want it to be offered at the initial assessment, and if the answer is kind of no or I'm not sure, it then not to be picked up later on. So we took this kind of issue around kind of this ambiguity about going back to work, but at the same time, we were recognising that some of our staff have an ambiguity about people going back to work. They're kind of a bit ambivalent themselves about actually, should we be helping people to go back to work? So we created a cluster trial, 4 first episode teams, 2 in London, 2 in the West Midlands, and we recruited 159 young people who only made the commitment to consider returning back to work or study. Of the 4 teams, 1 in London and 1 in the West Midlands were chosen to also get team-level motivation interview to help with that issue around kind of, if we could train staff to think about how to use motivation interviewing from a kind of employment education perspective where there's ambivalence, what kind of impact will that have? So, the aim was to kind of skill up our staff, but also the second part was to kind of think about with this training and just that process that staff are going through with young people, does it have an impact on their own ambivalence about helping people back to work? And basically the kind of hard and fast rule are, here you go. Here's the IPS outcomes in relation to kind of 6 and 12 months. 12% back into kind of education and employment, 6 months, 12 months, 38%. But in the teams where we, the 2 teams, 1 in London and 1 in the West Mids, where had a team level motivation interview training. So not just training the employment specialist, training all the team. You've got much, much better outcomes. Just working through that process. So it was a small study, but kind of gives reason to kind of think actually there's something in it and we kind of need to look at it at a kind of bigger level and just think about it as a kind of mentoring. Let's help our staff with that kind of ambiguity so that they can help young people with ambiguity. Implementation. Implementation is the biggest challenge. We know IPS works, but there's that whole challenge about how do you actually kind of do it and how do you make it stick in the system. If you think about implementation, there are kind of 2 parts to implementation science, isn't there? There's the kind of process problems, which is about implementation, and then there's the structural problems, which is about integration. They're the 2 things. If we can get past those 2 things, something will stick in the system. Thinking about it, I'm not going to talk in detail because I think others will, but just thinking about it as that individual level intervention. The employment specialist is integrated into the team. And actually it was Tom Burns who summed it up really beautifully. And he said, they're part of the team, they're not a resource for the team. And that for me kind of sums up, that's the level of integration we're kind of talking about. It's very much a very recovery-focused approach, which of course goes against a lot of the mainstream services, even EI teams, in terms of how they work. It's very individualised with clients. The clients actually shape that vocational pathway. And it's a very individualised approach when working with employers. It's not about signing up with kind of local employers who say, oh yeah, we'll do a bit of good, etc. It's really working with clients' preferences to find those specific jobs. But that means active job development. At a team level, an IPS actually is a team-level intervention. It's much more than the sum of the employment specialist. One of the key things when starting this work, and always rattles on and on and on in teams, is the kind of role ambiguity issue, introducing a new type of worker into a team. So the obvious thing is to kind of reduce any opportunity for that role ambiguity. It's about changing the roles and behaviours of health and social care staff. It's actually about changing organisational structures and the culture, but also about the systems and policies. Because in effect, what you're doing is you're shifting away from kind of treatment process outcomes to actually thinking about employment and education as your outcomes. I'll come back to the kind of issue around that process and outcome evaluation and the issue of fidelity, because I think just in terms of these kind of changes, what are we talking about? Now, each one of these is a kind of like half-an-hour presentation, but in summary, that importance at that team level of seeing and believing that employment and education is possible. If staff are in that position, then everything is possible. Shared decision making. And I mean this in this kind of proper sense. I hear too much of kind of care coordinators and others almost gatekeeping people as to when they're ready to go back to work or education or not. And the sheer reality is unless that young person is detained under the Mental Health Act or lacks capacity to make the decision under the Mental Capacity Act, it's their choice, not the clinician's or the care coordinator's choice. So kind of how we enact that is a real challenge. The other thing I notice a lot is young people will say what their goals are, and then you look in care plans, and there's this whole list of different treatment interventions. And I struggle, and I'm not a clinician, so I probably just don't see it. But I don't quite understand how the treatment goals and all these kind of different things that are going to be done to the young person, how they relate to the young person's goal. And surely there's that need to kind of think about, if that's the goal, how do we wrap around all the treatments and interventions to just enable the person to achieve their goal? That's the challenge, and that's the team level integration. Because everybody in that team has a clear role to play. The psychiatrists, the social workers, occupational therapists, the nurses, psychologists, and anyone I've forgotten, they all have their unique role to play in that person's journey. Supporting self-management. We talk a lot about helping people to get into work, but do we really equip and enable people to kind of learn skills to manage their mental health when they're at work or when they're at college? That use of natural supports. We often think we need a professional to be involved. They're the only person that can provide the support. That may be a clinician, that may be the employment specialist. There's so many natural supports that are around us. If we think about the supports we get in our everyday life from work, we get support from all kinds of people. Clients are no different. So how do we utilise and kind of foster those natural supports? And then that issue around supporting families and carers and really enabling them to kind of really come to life and help that young person. Because after all, they are some of those natural supports. Lots of young people still live at home. Fidelity. All it is a kind of how faithful have you implemented something to the approach. That's all it is, a bit like a marriage. What we do know is that it has predictive validity. Where services score moderate fidelity, they get reasonable outcomes. Where services score high fidelity, they get high outcomes. So there's a kind of fairly logical process in terms of kind of thinking through why it's important. People often say, yeah, but we've got these 7, 8 principles of IPS, etc. How would you do it? Read the fidelity scale. It tells you the what and the how of what we need to do. It gets used in research just to kind of say they were doing it. But actually, it's a quality assurance tool. We kind of talking about that on our table, about doing fidelity reviews to kind of see, are all the processes in the system working together to actually maximise opportunities? So it's about quality assurance. This is a piece of work that when we set up the Centres of Excellence programme at the Centre for Mental Health, Bob Grosh, Jeff Shepherd and myself were kind of just looking at kind of how do support services who are in kind of different levels, etc., to kind of really move this stuff forward and kind of make sense of it. And 9 different IPS programmes around the country kind of came on board as Centres of Excellence to kind of look at kind of how we do it. And everybody was at very different stages. There were some who were kind of very advanced, and had been doing things like IPS for many years, and some were just starting out. So we had very different levels of implementation, but here from those fidelity reviews that were conducted, so 16 in 9 different services, what came out as those system weaknesses, and that integration of the employment specialist into the clinical team, a real challenge, takes time, takes leadership, resistance, cultural differences, professional prejudices. We do employment. I hear it all the time from different groups. It's not about do we do it, do you do it? It's everybody's business. We all have the roles to play. Process of obtaining referrals. That's the gatekeeping bit. There's no shortage of people that tell us they want to return back to work. When push comes to shove, getting the referrals to care coordinators, that's more challenging. Then there's the importance of kind of just that general leadership, but also good quality training and supervision. In a similar way that Janssen CELAG and Johnson & Johnson has supported a whole program of work in America with the Dartmouth group in terms of implementing IPS across the states of America. Janssen CELAG have kind of set up a program which myself and Professor Joe Smith are kind of working on, where we're kind of providing very specific training to enable employment specialists who are working with people in their first or second episode of psychosis to kind of really master the kind of skills needed and to work with those transitional issues. But of course, one of the things that's really, really important is training is one thing, but then the implementation is another. And so with this program, there's a kind of whole year's implementation support to enable people not only to get trained, but to get up and running and build the confidence both at an individual and team level. It's all about recovery. And I think that's both an opportunity, I think it's a threat, I think it's a strength, and I think it's a weakness in everything that we're doing at this moment in time. We know from an individual perspective, employment and education are critical things. From a clinical perspective, we know that actually if you do this work and enable people to return back to work within 1 year of their first episode, the longer term outcomes are very, very favourable. What I just want to finish with is there's an international consensus statement. Rethink others all supported it at the time when we developed it in 2008. It just brought together people from all around the world who were thinking that this was an important thing to do. And it's had quite a life. There's a whole kind of group of people. You can download it from the Iris Initiative website. There's a knee group. And there's kind of every 2 years, there's a kind of meeting which brings together people just to share and talk about challenges that are going on in different countries, etc. It's a really important issue. Thank you.